Right, good afternoon. I know you all want to go and have your drinks and conversation. Without being effusive, thank you, Claire, for inviting me. And thank you for being a doctor to someone in the family. And it's truly remarkable what you've done and what you do, so thank you. And I want to say thank you to Sally Harris as well, a colleague, a friend, but the glue in my professional life. She's really helped me reach out to other people, so thank you both very much. I only have about 10 minutes, so I am going to give you a whistle-stop tour through perhaps slightly more medical-based view of heart health. I'll try not to talk too much about data and science, but just give you a flavour. So here are some crude statistics. I'll let you just absorb them, and whilst you absorb them, I'll tell you that, as Claire said to me, can you talk about heart attacks? Because let's face it, it's still the major killer. It is. 30% of deaths are due to cardiovascular disease. 1 in 14 women will suffer a significant heart event, and 1 in 8 men, so it's not that disproportionate. And under the age of 35, 60% of deaths are due to heart disease. So these are very powerful statistics. A third of patients who come into my NHS A&E with a suspected heart attack, you ask them, have you had any symptoms in the prior 6 months? No, nothing. Even in women, half of women will have no warning signs or symptoms. So heart disease is hiding in plain sight. We don't know it exists until it actually comes and bites us. So, sorry for the gory picture, but I thought you should know that this is a post-mortem sample because this patient's widowmaker artery, the artery down the front of the heart which supplies most of the blood to the heart muscle, was blocked. And we all think with the innovations of medicine, healthcare, complementary therapy, heart disease doesn't cause deaths, but I've already told you, it still causes a third of deaths. And 50% of people who suffer heart attacks will not make it to hospital alive. So it's still a big killer. So really, when we talk about longevity, we really have to stop the horse from bolting. And this is what a heart attack scenario could look like, but if you catch it early with a very well-nuanced GP who picks out trouble from Sniper Alley very quickly, you'll see just here a narrowing in the main artery of the heart. There it is just there. You can see a constriction, and it's been treated before the patient runs into any trouble. So, longevity. First of all, when we talk about longevity in heart disease, we talk about who's at risk. All of us are. Young, old, fit, healthy, overweight, underweight, smokers, non-smokers. No one is spared risk. In cardiology, and I'm a simple beast, not like some of you scientists who are very clever, and it's about reducing risk. That's what we're doing day in, day out. We're reducing risk. And this motto is essential to every patient I see, be it in my NHS clinic, NHS ward round, this morning's NHS operating list. It's better to stay out of trouble than to get into trouble. And for me, when I was invited to talk about longevity, this was the backbone of what I thought I should share with you today. And the real thing I want to share with you very quickly is risk management starts early. This is not about waiting until you get to perimenopause or you get to 40 or you're retiring as a CEO. It has to start early. There have been studies showing cholesterol deposits in fetuses at about 20% narrowing of an artery, very early on in most aggressive cases. So heart disease starts early. And this is just a graphic. Risk factors start in the prenatal phase. Then you have risk factors as a child. And then you have adult risk factors, just reinforcing the need for earlier intervention. How do we manage risk? Now, this is the buzz phrase, this is the catchphrase in the cardiac community globally. Follow life's essential 8. And it's broken down into life habits and life behaviors and traits. So I think you can work out what each of these sections are. So diet, exercise, blood sugar, weight, cholesterol, blood pressure, smoking, and as we spoke about earlier today, and I think this dovetails very nicely, sleep. Sleep in scientific studies in the cardiac community has been shown to have an impact on heart health. So Sally and I, through HCA, we've said this so many times to big corporates, to people who want to get health checks done, know your numbers. How many of you know your cholesterol? How many of you know your blood pressure? How many of you know your blood glucose? And your resting pulse? So with that simple information, you are armed and empowered, whether you're a private patient, an NHS patient, say, I know this number's not right because I read it in the Daily Mail and it should be better. And you can go to a healthcare professional and get some attention and help before something happens. So these are the risk metrics we look at. And what Sally does a lot of the time and what we work on is you take your car for an MOT every year, or you service, or you update your phone, but how often do you update your body? How often do you get a check done? How many of you have a regular, good, thorough health check on an annual basis? So about half. Okay. So undoubtedly, we will pick up potentially significant conditions for all the reasons I've shown you on the graph before they actually cause you a problem. So health assessments, health checks are pivotal for longevity. I won't talk too much about this, but the British Heart Foundation, the cardiac societies across the globe have defined metrics aligned with the WHO about exercise, and it is really about the combination of resistance, weight and aerobic exercise that needs to be done on a regular basis. And I'll skip on to the next slide. And again, this really dovetails very nicely to what everyone else has talked about, brain health and general health and well-being. There is only one diet that has stood the test of scientific rigor through clinical trials and been shown to reduce cardiovascular disease and stroke, and that is the Mediterranean diet. No other diet, whatever sort of diet that you want to think about, has been proven in a scientific arena to reduce events. So the one thing I say and send to all of my patients is this sort of graphic to remind them about the Mediterranean diet. So when we talk about heart attacks, Claire said, can you also talk about cholesterol and statins, do a bit of myth busting? So heart attacks are due to blockages in heart arteries due to cholesterol. There's no way of ignoring it. It is related to cholesterol. The one thing I'd say is we're all born with a certain amount of cholesterol. We all need it. It's essential. 50% of your blood test cholesterol this afternoon will be nothing to do with the biscuits you had a couple of hours ago. 50% is just your biological genetic makeup. It does not correlate with weight. It does not correlate with exercise. Okay? So we have to bust some myths. If you're overweight, you will not necessarily have high cholesterol, and vice versa. And statins have been much maligned in the literature. I've been involved in cholesterol risk reduction management for about 30 years. I don't mind being very bold and brazen, saying statins do not cause cancer. They do not make you psychotic and jump off the shard. They lower risk. They lower the risk of heart attack and stroke. And as we do everything in life, if you take an intervention for an appropriate, sensible reason, you will derive and reap the rewards and benefits. And when we talk about heart attack and strokes, it's keeping your blood vessels clean. And keeping your blood vessels clean means keeping your cholesterol as good as possible, amongst all the other risk factor metrics I talked about. And patients say to me, well, doctor, my cholesterol was normal. Why have I had a heart attack? I said, there is no normal. There is no such thing as a normal cholesterol. I've got patients having horrible heart disease on very low cholesterols, and I've got their husbands and wives who drink 3 gin and tonics a night, don't walk, 120 kilos, have no heart trouble at all. So there is no rhyme or reason in this myth that there is a fixed number which is safe. These are the sorts of numbers if you're interested, but I can always share the slides with you later. It's all about the bad cholesterol, the LDL. The good cholesterol, once you hit above 1 or 1.2, you really don't get any additional benefit. So I have many patients come to me and say, well, my HDL is really good, so I must be okay. Well, no, not really, not if your LDL is higher than your HDL, because that's the troublemaker. The LDL is the bad boy. And then, Claire, you asked me to talk about this difficult topic, and you're probably going to catch me out on this. So we often have this dilemma about hormone replacement therapy or menopause therapy, heart risk. What I can tell you for a fact is that estrogen protects women against cardiovascular disease, heart attack and stroke. That's incontrovertible. Once women start approaching the menopause and go through menopause transition, their risk increases exponentially. And if you look at the curves, their rate of heart attack and stroke exceeds that of a similar age male. So there's no doubt that the loss of hormonal protection is pivotal. And certainly there are lots of things that happen in the body which other people have spoken about this afternoon, so I won't elaborate the slide, but changes in muscle, changes in cholesterol, blood sugar, inflammation in the bloodstream. Just like a volcano erupting, the blood becomes very inflammatory and sticky. And all these factors increase the risk of heart disease, stroke in women going through the menopause and coming out. So should we be giving everyone HRT? And thanks for that challenging question, Claire. My opinion is as follows. We always have to be personalised in our approach. If you're perimenopausal, your brother had a heart attack at 42, your aunt had a stroke at 55, your mother's got a blocked artery in your leg, I'd be having a conversation about HRT. And it's a conversation, it's not a directive. If you are going to start HRT in the right group of patients who are at increased risk of heart disease, you should start it sooner rather than later. You seem to lose the benefit if you leave it for 10 years or more. And certainly, it seems as if transdermal therapy, skin patches, are safer and as beneficial. Innovation. So things have come a long way from seeing a doctor in office with an old-fashioned blood pressure cuff and a stethoscope. You can walk into one of our HCA hospitals, come down from the train on Cheshire in the morning, one of Sally's patients, or many of them, have a CT scan pre-booked, go in the scanner, 20 minutes, come out, and I can see your heart arteries in detail. I can tell you if there's a blockage. I can tell you if there's any early cholesterol change. I can sometimes tell you that, oh my gosh, you've got an early lung cancer or even breast cancer. So innovation and technology is going to early imaging, early inspection of your heart. We also undertake lots of fancy blood tests now. There's no such thing as, oh, can you just do my cholesterol and blood sugar? These markers at the bottom, they are influential in contributing to the development of narrowing and blockages in the heart. And it's about everything in life, isn't it? Many people have spoken successful in business and entrepreneurs. The more data you have, the richer your assessment will be, the more productive it will be for you as the patient and the doctor to lower your risk. So when you do go for your health check, I would advocate you ask, can you please check these blood tests? In fact, I'm getting patients now saying, oh, my uncle, a cardiologist in the USA, said I should have these blood tests. Can I have them done? Yep, well, we can organise them, and I think that's reasonable. Other innovation, we can predict the risk of heart attack and stroke by a blood pressure machine. Not just looking at your blood pressure, but looking at the elasticity and stiffness of your blood vessels. Heart disease is aging. but it's aging that occurs early. When we age early in our blood vessels become stiff. And when they become stiff, they increase the risk of stroke, heart attack, kidney failure. So when a patient goes for a health check now in one of our 8A facilities, they have a blood pressure machine put on, they try and relax 3 readings, and hopefully they'll come out with a smiley face, not a downward smiley, frowning face, and we can tell them your risk with other factors. This is not a one-hit wonder. With other factors is low, medium or high. But then there's the real world. This is just a bit of light-hearted humour. I've been doing this for over 25, 30 years, passionate about risk. And I work in the NHS. And I've looked after a lady who I will never forget, and I'm sure Claire and Sally, you'll always have one patient you will never forget. I did her procedure in the morning. She had 2 blocked arteries and she was getting chest pain. She had been a smoker, and if you wanted to pay for the procedure privately now, not using insurance, it would cost you £25,000. And about 6 hours afterwards, I went up to the ward to see her, to do my rounds before she was going to go home. And I walked up to her, and this is what I saw. This is not made up. This is on my hospital ward. Let's face it, what's wrong? Well, what's right? She's well read. What's wrong? Not just the fries and the box from McDonald's. What was wrong is 2 things. One, we didn't educate the son, because I said, what's this doing here? He said, Mum hasn't eaten all day and I thought she could do with a treat. And secondly, the catering staff gave her a cheese and coleslaw sandwich. So although I talk about risk management and things, I think someone said it earlier, we are all responsible through connections, through networks, to try and improve the health of our patients and our loved ones and friends. And finally, this is my mantra. Thank you very much.